on the cortex of the forebrain, at least that layered cortex. Yesterday we talked about the olfactory cortex as essentially being non-layered, basal clumps of cells, and the reason the anteperiphery space. Today we come into the more structured cortex, first of all beginning with the limbic system and then progressing on into the neocortex. The key to understanding the general anatomy of the limbic lobe is in relation to the development of the temporal lobes as they spiral back from the rostrum and around the temporal poles, because that migration takes with it the fornix, hippocampal formation in that same spiral, and parallel with it the caudate, body and tail. So we have a number of structures that trace this spiral pattern. When you look at the brain with the ventricles open and look at it from behind, as you see the fornix rotated backwards, coming from the rostrum, coming backwards and spiraling out, it has reminded someone of the ram's horn, starting from the skull and going around like so. The only difficulty with that is that most pictures of rams, goats, sheep I've seen, the base of the horn is thicker and the tip becomes thinner. And this seems to be backwards, at least when you look at the rather thin cornices and the rather broad hippocampal formation as it comes back and around. So maybe you could find me an example of a goat or something that has a horn like that. Anyway, that's the cornum ammonis, the horn ammon. Ammon being who? David? Ammon. Ammon was the Greek god, the ram, and he had this roughly had this shape of horn. So that's the reason for the gross pattern and the reason for the naming of the cornum ammonis. The next pattern to be recognized gives the name hippocampus, which is a seahorse. A seahorse, of course, has a nose, mouth, neck, and belly. And the real seahorse, his tail curves around in front. But of course, the hippocampus that we'll see in the cross-section has a snout, which is essentially the fornix, and a head, which is essentially the hippocampus, and a belly, which becomes the parahippocampus. The tail keeps on going around behind. So there are two little anatomical, phylogenetic problems with the names that we're running into. Let's look at this in a sagittal view. Get oriented first. The anterior commissure, optic chiasm, armory body, lamina terminalis, pituitary stalk, floor of the third ventral aqueduct. The corpus callosum, splenium, body, genu, and rostrum, developing as fibers cross in the region of the anterior commissure. And the fornix fibers, beginning just behind the anterior commissure and being swept back and around into the temporal lobe, beginning as the pyramidal cells, axons of pyramidal cells, in the hippocampus. And so we have a number of these as they sweep from front to back. They pile in here, picking up the fornix. So we have a big bundle of fibers that are making up a very nice bundle that's easily seen by MRI and gross naked eye dissection. These fibers come down, penetrates the hypothalamus, and end in the mammary gland. And as you recall, from the addition of a callosal fiber and the septum pellucidum, some of these fibers were precommissural and were stretched out around the corpus callosum, so that they are aberrant fornix fibers, the same kinds of fibers that make up the main bundle, but can be above the corpus callosum, can come through it, and so one has a variety of small, very minor pathways that trace the embryologic and phylogenetic development of the hippocampus. Like I said some time ago, there's animals with a very small corpus callosum, hippocampus way up here. And some of the eyes, anyways, I'm surprised to see hippocampus above the corpus callosum, but it's really a failure of callosum to develop and push the fornix back way down into the temporal lobe. The afferents to the hippocampus, finish the drawing here, basal dendrites and apical dendrites. Somewhere I have notes myself. The dentate gyrus cells, small cells, closely packed, send their axons down to basal dendrites, and perihippocampal neurons further away send their axons mostly to superficial parts of hippocampal neurons, triangle cells. So, I'll label these for you. Dentate and perihippocampus. And to show the relations of these in a cross-section, in a more realistic pattern, let me draw a coronal view here. That would show the interlocking C's of the dentate gyrus and the hippocampus and the perihippocampus, which, if this only curved the other way, would look more like a seahorse with its snout up here, and its head, body, and tail going the other way. So dentate and perihippocampus. Hippocampus. Like so. And what these pyramidal cells do, sideways now, they send their axons up into the white matter immediately beneath the addendum of the temporal horn, known as the alveus. They sweep around, they collect over here as the fornix. And the fornix is passing front to back in this hippocampal formation and eventually rising up behind the diencephalon above it and back down and around. Any problems so far? Now, according to Nauda's little book here, the dentate gyrus projects mostly to CA3, and CA3, I have it straight here, contributes to the fornix, of course, but also projects back to CA1, and back into entorhinal area, which is the top medial portion of perihippocampal region. Of all of these hippocampal formations, arbitrarily named 1, 2, 3, and 4 in the island there, contribute to fibers of the fornix. Dentate receives fibers from, what did I say? It's lost. Yes. So entorhinal cortex over here. Provides the fibers that come into the dentate. Now, this forces us then to speak of another part of the limbic system, which includes the perihippocampus and the cingulate gyrus. So, put that in. We have the gyrus just above the corpus callosum, continuing around. Here. Parallel again to the other spiral. And contributing fibers that sweep in the cingulate bundle. Making a heavy white matter tract. If I draw this, if I finish this drawing, let's go over here and look at the corpus callosum and the cingulate gyrus, the superior funnel gyrus, middle, inferior, and insular cortex. The gray matter something like that, or cingulate gyrus. And the cingulum here, green, which represents the output of cells into the cingulate gyrus and running, clearly in the white matter here, running at right angles to the board. But we have a major bundle of white matter running again in the same spiral around the corpus callosum into the temporal lobe. And that is the cingulum. White matter of the cingulate gyrus. And the next step in this, going backwards again, is to look at the thalamus. And particularly the anterior nucleus of the thalamus, which also gets drawn out in this spiral pattern. And it projects through the internal capsule into the cingulate gyrus. So if I put the thalamus down here, below the corpus callosum, let's put the line here, epithalamus, thalamus, hypothalamus, thalamus. The intermedullary lamina, center median, so we have the anterior nucleus here. Giving rise to fibers that sweep around into cingulate gyrus. Maybe like the rest of the ventricular system thrown in here. So the caudate over here, and so we have a pendula coming over the lamina fixa, over the caudate, under the corpus callosum, down to the septum, fornix, choroid plexus, and over to the lamina fixa. So here's lateral ventricle. Here's choroid plexus to the opposite epithalamus. Any problems so far? And then, of course, we have the mammillothalamic tract right up into the anterior nucleus. So down here we put the mammillary body, and it's tracked very straight up. Very heavily myelinated, very obvious bundle, grossly. This is the mammillothalamic tract, the Victazir. She's doing something else. It's a nice name. But anyway, that's that part. So if you follow the scheme, we have the parallel spiral development of the fornix hippocampal system, of the callosum and adjacent cingulate gyrus, hippocampal gyrus, and essentially a closed loop. A potentially reverberating cycle. We start here in the hippocampus, into the fornix, the mammillary body, the anterior thalamus, the cingulate gyrus, through the cingulum to the far end of that, parahippocampal gyrus, into the dentate, and back into the campus. And this is one system that can behave actually as a closed reverberating loop. We see it sometimes in some patients with temporal lobe epilepsy, where they are able to see, hear, move, even drive a car, even get up from the table, go out and wash the dishes, rather complicated behaviors, and yet have no memory of it. Because this limbic system, in some way, is responsible for converting immediate sensations into recent memory and then into long-term memory. And people who have lost a major part of this, particularly in the hippocampal formation, have difficulty with recent memory. Their old memories are intact. Their present abilities are intact. So that I could be talking to you as I am and leave the room and back in 5 minutes and give you the same speech, forgetting that I just told it to you. We see this in certain patients who have tried to commit suicide, say, with carbon monoxide, and just failed, and just knocked out their hippocampus predominantly, and perfectly nice people, except they can't learn a thing new. There are 2 patients who were operated on in the 1940s early for relief of epileptic seizures and campus taken out bilaterally. And they were fascinating subjects for neuropsychologists, particularly the Boston group and the Stanford group. And they were unable to learn anything. One of them, a fellow studied by Huntsman and Stryber in Boston, born and raised in Baltimore, moved all around Baltimore. Childhood, everything's fine. He could not learn his way within the lab in Boston, much less the lab at home. So that part of that operation was stopped rather promptly. And even today, when Dr. Ogeman, for example, has done a lot of temporal affections, a lot of hippocampal removals, he has to be careful that the other side is all right. The other side is also damaged. Taking out the target side can produce a drastic loss of memory. And the same thing happens in epileptic seizures. One can have recordings of electrical activity, epileptic activity going in the circuit for minutes to hours. During that time, this system simply doesn't work. It's obvious it can't work if you take it out. It's likely equally obvious if you're putting the equivalent of nonsense into it. It can't make sense of anything else. So these patients can get up. I watched a patient playing bridge. Put her hand out, excuse herself, and get up. Right in the middle of the hand, she was playing. She got up. Went to the kitchen, fumbled around the kitchen, trying to make sandwiches or something. Came back and sat down and had no concept or memory of what had happened. All kinds of bizarre things like that. The Alzheimer patient loses function of hippocampus probably about the first stage of the disease. One of the common signs is the inability to remember anything recent. I watched another patient at Thanksgiving dinner. I was seated to her right. My brother-in-law to the left. She turned to me and said, "I ever told you, Buster, about my father, how he sailed from Ireland on his stars?" She went for 20 minutes. This fanciful tale of how this old Irishman had sailed from Waterford and so on and so on. Having finished that, she turned to her nephew and said, "Jim, have I ever told you?" And she gave the same story over again, word for word. I mean, just a recording that she had. She had no idea that she'd done that. After dinner, her son, who'd come from Ohio, Chicago, party. Left. Within minutes, she was telling my wife how nice it was that she came because her son never came. Just totally forgotten this whole episode, several hours before lunch, and so on. In a way, it's comical, but it's really quite tragic to watch it happening because the family doesn't understand, the patient obviously doesn't understand, and all kinds of misunderstandings can occur. And one can imagine changing wills, disinheriting people who are taking care of you. You just have to remember. So it's a fairly important little system here. The only one that we know that is basically set up for a reverberating circuit. And the only one that we know that actually can function as a reverberating circuit. And while that seizure is going on, or while activity is impossible because of a lesion, the rest of the behavior is pretty good. They don't necessarily have any other, even electrically recordable activity, much less gross clinical effects. Without having gotten it set up as a reverberating circuit, how do we get into it? And how do we want it? And that, of course, is another small bit of the story. There is a small amount of olfactory input. The olfactory tract fibers coming back on the surface and ending into the entorhinal cortex. Coming in from olfactory bulb, tract, back into the basal olfactory cortex and turning around at a sharp angle, to exaggerate the length of it here, to come into the most anterior medial part, the temporal lobe that has grown over the lateral fissure, and has this lateral piece of olfactory striatum. So there's a small amount of olfactory stuff. The major input, though, is from all the adjacent cortex. So we have input from our olfactory cortex, from frontal, central, parietal, occipital, other temporal cortex, a whole host of other inputs into perihippocampus, cingulate gyrus, that whole system, that belt around the, belt around the diencephalon as the telencephalon has developed this spiral. And then how do we get out of the system? We can put in the hippocampal commissure to the other side, which at first glance ought to be a way out, except because it gets into the other side. We shut down that one. So that just makes the system bilateral. But we can have some input from the fornix and these other aberrant fibers into the hypothalamus. The major way out, though, turns out to be, the major way out anyway, is a bundle of fibers coming from the mammillary body and not going to anterothalamus, coming down into the midbrain reticular formation of a Miner's tract. So one can begin to appreciate, I think, how a wide variety of inputs can get in And sometimes these seizures can affect particular formation of brain stem and produce or lead into a generalized convulsive seizure. And to me, the remarkable thing is how rarely that actually happens. One other disease that I ought to mention is, of course, the Wernicke-Korsakoff syndrome. Vitamin B1 deficiency, basically, with the lesions predominantly in mammary bodies, in the wall of the third ventricle, wall of the aqueduct, floor of the fourth ventricle. But there are other components, third nerve, sixth nerve, palsies, for example. But one of the striking things of the Wernicke-Korsakoff patient in the healed stage is he makes things up. He's fabulous. He can't remember what he had for breakfast, so he'll tell you what he had. And it might be characteristic of the alcoholic personality, who might tend to be garrulous and confabulate. Anyway, but it's certainly exaggerated when they don't have this system working.
Is there any that projects right back to adjacent cortex?
Right back to
adjacent cortex. You said that adjacent cortex was the major input.
Here in the singular gyrus system. Well, I assume that there are two-way connections. I don't know that. Most cortex would have U fibers, short connections, so I wouldn't be at all surprised there are U fibers. It could easily be a spread from singular gyrus location. And there is some feeding back from CA3 to CA1 and entorhinal cortex. There's a definite, I think, rather small amount of two-way connection.
Is memories, even though they're formed in the hippocampus, aren't they stored in the cortex?
Memories are stored in the cortex?
Well, that was a question.
That's a question. It remains a question. It's probably a Nobel Prize winning answer. If one can figure out how immediate sensations are converted into recent memory and then stored as long-term memory.
And the people who had their hippocampi removed still have those old long
Right, so they have old memories. Those have been stored somewhere in some fashion.
They're not in the hippocampus.
And are available. It's clear that the hippocampus is not essential for that. It's not clear that the hippocampus is a store somewhere. It's not quite clear how this reverberating cycle of hippocampal activity, taking this auditory, this visual, this somatosensory, and so on, input, parcels it out, combines it, puts it someplace. There are arguments for it being stored as DNA, for being stored in little patches of cortex, for being stored. It does not seem to have a localized site. There isn't a safety deposit vault that we found anyway yet. Some of the stimulation experiments in the human cortex suggest that by stimulating the right spot, you can begin a motion picture at different points in the motion picture, of scenes that can store. But it's never been clear to me whether that's sort of recruited in as part of the epileptic process for which the operation is being done in the first place. or that it was actually stored there, by analogy with a roll of film, and you just simulate it 10 feet in or 100 feet into the roll. My guess would be that the stimulation goes someplace else and recruits something else. That it's not likely that there's a little patch in which that particular film is stored. But Mike has been working on this, and maybe there's some other ideas as to how these things are packaged.
What we know it's not is some grandmother cell or something way up in very association cortex, because one of these patients that Damasio had was in Boswell, and he had encephalitis and it knocked out basically like both his medial temporal lobes, and he has complete short-term memory loss. They've done studies on him. You can see that even if you take out the anterior part of the temporal lobe, memories aren't like stored in a specific spot. People are going for right now, one of the things people are looking at is this sort of parallel processing of memories, and then you bind it all together by having, whether you want to use oscillations or whatever you want to use, that basically synchronized activity, at one specific point in time in a number of different areas actually puts together the memory preset kind of thing. It's not like usually going to be stored in one specific spot in the cortex.
That makes sense to me. It just seems like if it was somehow an oscillation of the hippocampus that was just causing an output and causing it long enough to cause some long-term change in it. It seems to me that we want to have that output reverberating right back into cortex, reverberating around the hippocampus with this amount going into cortex long enough to have some pattern become easier to occur. So I just wondered if there was a more direct output from it than all the way back down to the brainstem, collecting somehow, and then having to get it back into the cortex.
Well, there's no question in my mind that retention of memory is an active process. That one can remember an episode better if you've told it before. And in telling it again and again and again, the memory of it becomes clearer and clearer and clearer. And of course, you're not quite sure how much of that is being manufactured as you, quote, remember again and again and again. But my wife, for example, has the ability to remember almost perfectly what anybody was wearing at any occasion. And from that clue, she can remember the whole occasion. And she can, I think, see you with a red and green shirt, which she would probably find God awful. So it would stick like that. But and she obviously doesn't do it by remembering that I wore white socks. I always wear white socks. There was something else that I was wearing. Caught her attention at the time. It was very unnerving to have her meet somebody for a long time. Oh, yes, you were wearing that. That's the whole dang outfit that she was wearing. I can hardly remember what I had on yesterday. Must have left on this morning. Just happened to be next thing up. And there are a lot of interesting things on people who have multiple languages and being operated on for epilepsy and be simulated in one place or another and inadvertently taking out the piece that was important. And in general, losing their most recently acquired language, stuff like that.
Well, there's some thought that your secondary language is sort of more widely distributed. Like you go around sitting at the surface of the cortex and find like 2 spots in the temporal parietal lobe that knock out your ability to name when you stimulate there. Clearly that's an essential language area. But when people are bilingual, or more secondarily acquired language tends to be a little bit more widely distributed. So when you stimulate there, maybe they hesitate, or maybe they make an error in pronouncing a word or something like that, but they don't. It doesn't completely wipe out their ability to know. So language stuff is very interesting, that you can see sort of this association between where one language is from the other. I mean, even in interventional neuroradiology, they're able to use selective blotting and show they knock out somebody's eye, but not for English, and they inject certain areas of cortex. So, yeah, that's different. That's different. That's for language, more for language.
So any other questions on limbic system?
When you look at the CA fields in the brain of a patient who suffered from cardiac arrest, which fields are more degenerate?
Okay. I've been hesitating to get involved in that discussion. I'll try this again. The dentate gyrus and the hippocampal formation, the parahippocampal formation, it's three C-shaped patterns, are divided in terms of layers of cells, types of cells, and density, compactness of cells. The hippocampus proper is essentially one layer of rather homogeneous pyramidal cells. And that runs approximately from here around. And it's rather thick and thins. Up here, about H2, is very densely packed. So it's less dense, exaggerated now. So CA1 or H1, CA2 or H2 are rather sharply dividable in terms of the density of these pyramidal cells. As we come into CA3, and then down here into CA4, or H4 and H5, 4 and 5 are fairly easy because they take another angled turn in the hilum of the dentate gyrus. But there's a decreasing density of cells, and the boundary between CA3 and 4 is, to my eye, not very sharp. Here in the beginning of the parahippocampal gyrus, we have more layers of cells that increase. So eventually you end up with 6 layers over here from the single layer that we had back here, with some islands of cells in this general area. So this boundary is relatively sharp, as it's not knife sharp, as more layers piled in. Now the lesion that we see is better known as summer sector. Summer described the lesion. 20, 30 years before the normal anatomy was begun to be recognized. by Bonaconomo and Rose and what's his name? Anyway, the normal anatomy came in later, and people tried to superimpose the two and say that it was a CA1 lesion. Well, CA1 is probably the first or mildest lesion to be recognized. But the lesion can slop over into hippocampal formation or into even CA2. My impression is that CA2 can thin. CA2 is the so-called resistant sector. But it's relatively resistant. One can recognize it because of the density of cells, and it doesn't seem to be as densely populated as normal. The hilum. So if I had to number these, I would say CA1 was probably the first, and the hilum CA4 or H45 was next. CA3 maybe the next, along with some perihippocampus maybe. And CA2 the last. The dentate gyre still comes in here somewhere along about 2 to 3 and becomes most easily recognizable as breaks in the sea, or patches of loss of cells, meiosis. And the argument continues as to why this pattern does not correspond to the normal, why it's so variable. And one thought has been that there's a blood vessel coming in here through the old hippocampal sulcus, which has now been sealed shut between the dentate and the perihippocampus. So-called Uchimura's artery. A branch of the posterior cerebral or of the anterior choroidal. The anterior choroidal is coming in above the hippocampal formation into the choroid plexus. So we have either posterior or anterior choroidal arteries. It makes sort of an accessory front to back collateral circulation. Posterior coming from posterior cerebral, anterior coming from carotid. Uchimura is supposed to be coming from posterior cerebral artery. And branching like a rake to supply various parts of the hippocampal formation. And a separate branch, I think, comes off like so, to supply the dentate region. And so one of the arguments has been that swelling of the brain and compression of this artery produces local ischemia in the territory of one or another of these branches. And that I thought was a very satisfactory explanation for some fairly discrete, complete loss of neurons from local ischemia. The only difficulty with that is that Dave Newell now has a system where he can culture slabs of hippocampal formation, expose them to anoxic conditions, and show the same kind of graded increasing loss of neurons. And that then takes us back to the old idea of OGT, about 1910 or so, who developed the concept of pathophysis. Which said that there were specific metabolic activities of specific neurons that allowed them to be first infected by, say, poliomyelitis, was the first major example, injured horn cells in the spinal cord. And now I believe there's probably receptors that poliovirus can attach to into the cells. But at least something specific about those cells that allow them to be infected, and something specific about the metabolic activity of these cells that allow them to be specifically more or less sensitive to hypoxia or other metabolic stresses. Ideas come in cycles, and spirals, and circles. And we've just about completed the circle. It's taken about 80 years to get there. But I dare say that there's going to be a little variation on the spiral out somewhere here.
And CA1 is supposed to have the highest density of like NMDA receptors in the hippocampal. So some people suppose it's more of an excitotoxic type of phenomenon where if you block NMDA receptors, you don't get the huge influx of calcium you'd otherwise get. It's a protective effect for those areas. But I think that's, like you say, spirals. So
Yeah.
That's the hot topic of the day.
Thank you. That's the sort of the hot area these days, Ray, for pharmacologists, chemists, neurotransmitters. That too much of a good thing is bad. There's only a minor variation on the Chinese concept of yin and yang. I want this to be in balance. Too much good is bad. A minor variation on the homeopathic concept. You've got a little enough of something that's bad and good for you.
If we have a complicated enough system, it's a minor variation on everywhere.
Right.
So in Anton syndrome, where you have bilateral PCA infarcts, cortical blindness, and memory loss, is this the area explained by Uchimura's artery? You include?
I don't know specific examples, but that seems reasonable. And posterior cerebral artery is supposed to give off Uchimura's artery, and that would certainly involve campus. As I said, though, there is an anterior-posterior collateral circulation, so that when Irving Cooper was ligating anterior carotid artery for treatment of Parkinson's, I don't believe he had troubles with the hippocampal formation so much as he did with the adjacent optic tract geniculate internal capsule, which is also supplied by anterior carotid artery. There's enough collateral circulation in most patients, say 70% of patients anyway. Cooper was able to ligate the anterior carotid artery and have a selective loss in the globus pallidus with a good effect on Parkinson's. But in maybe 5% of patients, they would have a more or less devastating contralateral hemiplegia, hemianopsia, hemianesthesia. And so he gave that operation up, 70 of them or so. That's related to the anterior-posterior anastomonic channels. So the anterior posterior extent of the hippocampal damage, I would see unpredictable on a purely vascular basis. It depends upon how much collateral circulation there is. Or how much collateral circulation there is not. It was compression of this artery in the process of delivery, and compression of the head, molding of the head, and transient herniation that produced this lesion that Penfield and Aldrin and Earl postulate as being the cause of temporal lobe epilepsy occurring years later, with this lesion as the cause of the fits. My guess is that's not the case, that the lesion is the result of seizure. And if the lesion is the result of seizures that are producing swelling, compression vessels, and the lesion expands, becomes a vicious circle. And the lesion contributes to more seizures. So it's I think it's unlikely that the birth injury story is really going to hold up. And I'm not yet persuaded that just taking out the hippocampus is the critical feature. That was just have to prove that. But it is remarkable how constant this lesion is in general terms, not specifically in terms of CA1, 2, 3, and so on, in the specimens we get from Bozeman's temporal epilepsy. It's a rare case we don't find something. Well, we've took the hour. So we'll start on neocortex. 6:30, same time, same place. And so we ought to be able to get through neocortex, which I'll warn you in advance, gives a chance to review all the rest of the nervous system. Essentially everything projects into it. Through the thalamus, of course, we get a chance to review that. And we'll start with, say, Monday. Tuesday, probably go towards intervasal ganglia, capsule. I'll be able to finish next week. Which is why. No, it's not. When do you leave?
No, we don't know that.
Thursday, we may, I think we're going to be an hour late Thursday. So we can have class next Thursday. We only have one case of